get started. How are you guys? Doing alright? Okay, so today's first lecture is on pain conditions. So analgesics are the second largest type of product that are sold in the over-the-counter section. And so this is probably where a lot of your questions are going to come from, and then you'll also get this dispensed in prescription version too. And there's just a lot to be aware of. A lot of the products have line extensions in this category. So you just basically have to be kind of careful of what the active ingredients are. And there are analgesics hidden in a lot of products, like cough and cold products. Things like Dayquil typically have something like acetaminophen in them. So it's just good to be aware of straight off the bat. So that's kind of where we start. I think everybody took the quiz, so that's the format we're going to follow for the rest of the semester, and they'll look very similar. So the same types of readings, the same types of questions, the same length of quiz, so kind of know what to expect. So what are we going to talk about today? We're going to talk about how you assess a patient who comes in with a complaint of pain. We'll talk about who is not a candidate for using over-the-counter products. And then we'll really differentiate between the three major classes of products that we'll cover today, how they work, when they're appropriate for use, in which patients, side effects, and other kind of just big general kind of core components of the medications. We'll talk about building regimens based on specific patient characteristics, and this will be very similar week in, week out. And then we'll finish up with sort of counseling points and what do you tell the patient. Okay, so what is pain? Pain is sensory, right? It can be a way of telling us that there's an injury present. It can be uniquely a symptom, a diagnosis, or both. So you can be diagnosed with having a pain syndrome, bless you. You can have pain as a result of something else, or you can have them together. So some people actually refer to pain as the fifth vital sign. It is unique though in that it's very subjective. And we'll talk more about that throughout the day because that's kind of a key when it comes to treating pain. It's very variable and it's very personable on how people respond and rate pain and feel pain. Because it's relatively subjective, there have been a lot of scales introduced to try to make it more objective. So subjective is things that are reported. It's what you're told. Objectives are things that you can measure. And so if we have something that's more measurable, sometimes it's more consistent, reliable, it's more standardized. And so pain scales are a way to make things like pain more objective. The one we'll probably use the most is a numeric intensity scale, and that's probably when you go to the doctor what you hear the most. So on a scale of 1 to 10, 10 being the worst pain imaginable, how's your pain today? Sometimes for people who have communication barriers, children, people who maybe English isn't their first language, you'll use other alternatives. So there's a pain scale that's simple, descriptive. Sometimes the visual analog scale has colors. So red will be on the 10 side, green will be on the lower end, and then yellow kind of in the middle. And then Wong-Baker faces are usually used in addition to the numeric scale, and that's really prevalent in kids, and that's actually why it was assessed. So any ideas about the downsides of pain scales like this? What might not work about pain scales?
I think everybody's pain intensity is different.
So Brandon said everybody's pain intensity is different. So yeah, what's a 4 to me might be a 10 to Kristen. Maybe I'm just really tolerant of pain. Matt, do you have another one? Same thing. Yeah, that's probably the biggest thing. So you just don't know what people's tolerance is. And so that can be a little subjective still. When we talk about pain conditions with over-the-counter products, we're going to focus on headaches today because A, that's what your book focuses on, and B, that's probably the most common reason you might get people to come in. But just know that you can use these for any type of over-the-counter pain, and the exclusions are going to be roughly the same. You'll also see it with muscle and joint pain, which we're going to talk about next week. Okay, so looking at headaches, and this is where your reading's focused, you've got two main types of headaches. You have primary headaches and secondary headaches. So primary headaches are ones that aren't really associated with anything else, and these are the majority of the ones that you'll probably treat with over-the-counter products. So the ones that are bold are the ones we're going to focus on. Everything else is just more kind of FYI. So one of your readings was on tension headaches, also known as stress headaches. Probably everybody in this room gets those. And they can be either episodic or chronic. You can have them ongoing, or they might come every so often for a set amount of time and then repeat every so often. Migraine headaches, we'll get into differentiating those two here in a second. They're fairly common. And then medication overuse headaches are another type of primary. And the main secondary headache we'll focus on is sinus headaches. Secondary headache just means that there's something else that's causing that pain. Okay, so knowing what you know after going through the readings, tell me some things about a tension headache that you would look for in symptoms. How would you differentiate that? What kind of
Neck pain.
So neck pain. Typically you see it in neck and shoulders. What else? Yeah, so Pam said like a band. So it's going to be like a vice grip. It's going to either go across the top of your head like a headband or across the front. They're typically bilateral, so they're on both sides.
So can it
Yeah,
be
Mark?
on one side?
Most of the time not. So tension headaches, kind of the key is if it's bilateral, so if it's on both sides, most of the time it's going to be a tension headache.
Even in the neck, like could it be on one side of the neck?
Yeah, if you sleep funny, you know how sometimes you sleep and you get kind of a kink in your neck? You might have pain that's more one-sided, but typically you're going to feel on both sides. It might be slightly worse on one side, but it's typically both sides. How would people describe it? What are they going to say it feels like? Pressure, okay. It's going to be throbbing. It's going to be, pressing or pressure is a big one. How is it going to start up? Are they going to say, it just came on and it's immediately really bad? How are they going to describe the onset?
Starts off weak and then increases in intensity.
Yeah, it's gradual, so it builds. Tension headaches typically build. You guys know that. You start out with a headache in the morning and it's always worse when you go home at night, right? Those tension headaches when you're stressed. How long does it last, tension headaches?
Hours.
Probably hours to days. Some people get tension headaches that last a little bit longer than a day. And what are people going to complain of in addition to the pain? What's an associated symptom? We talked about neck and shoulder pain. That's a common one. Anything else? A lot of people say scalp tenderness is a big one. And again, it's because it's kind of the whole head is involved. So why do you get tension headaches? What are the triggers for tension headaches? Stress. Stress is the big one. Sometimes emotional imbalances, so depression, anxiety, people can have headaches that come from those emotional triggers. And sometimes it's, things like positioning. So if you are hunched over a computer, you may be more likely to have a tension headache because your alignment is off. So it's all based on kind of musculoskeletal triggers. Okay, compare that to migraines. Very, very different. So let's start with triggers for migraines. So what's most likely to cause somebody to get a migraine?
Foods.
Certain foods,
Light.
certain smells, light.
Alcohol.
Sorry, say again? Dehydration, possibly. Sounds, loud sounds. So those are triggers. Not everybody gets migraines. I would say roughly a third to half the population probably suffers from migraines. So it's not everybody. Stress can be a trigger too. So you can have migraines that are triggered by stress. Hormones are a big one, especially in women. Poor sleep. So we'll talk about kind of the risk factors and how you prevent those. So how are they going to describe their pain in a migraine?
It's in one location.
So it's unilateral typically. It's half the head, one side or the other. Some people get them on bilateral, and some people will get them where they start on one side and they sort of spread. And there was a good picture in your readings that showed that. But typically they're more one-sided, or at least they start one-sided. What else are they going to say about the headache? Somebody over here.
Sudden.
Sudden onset, that's very true. So migraines come on very quickly versus the gradual onset of a tension headache. That's a big way to tell them apart. What else are they gonna say?
Have an or,
Sorry.
they might have an,
Throbbing, okay.
might have an or.
So an aura is another big thing that's a difference with a migraine. So some people, not everybody, but they'll get this premonition that they're gonna have a headache before it actually has an onset. Does anybody get migraines? Okay, so I thought about a third to a half is pretty close. How many people get auras with their migraines? So a very small percentage of the people who actually get them. Does anybody want to share what it feels like? I'm not a migraine sufferer, so I don't really know. What do you get, Peyton?
Like when I first start getting it, like I'll be able to see, but I won't be able to see like your nose.
So it's kind of fuzzy,
Yeah.
vision changes? What do you get?
Like, it'll usually be in one eye, and it's like a rainbow sort of coloration, and you can't focus. Like, one time it happened when I was driving, I had to pull over because you can't see one of your eyes.
Some people get halos. They'll see like, or like fireworks, like you're describing in their vision field, typically off to the sides. So very sensory. If we could say it one way, I think sensory is a good way to summarize migraine symptoms. The triggers are sensory. A lot of the symptoms are very sensory. So these are typically more throbbing. They sometimes are more intense than tension headaches, so people will rate them slightly higher on a pain scale, but not always. And I think we've covered, how long do they last? Most migraines. Typically migraines do last longer, so most people have them for a day or two, but it's very variable. So can we tell the difference between migraines and tension headaches? Big thing with tension headaches, they're gonna say vice grip. It feels like my head is in a vice. It feels like somebody's squeezing on my head. And that's definitely a good way to know that it's a tension headache. Okay, sinus headaches, less common, very easy to tell apart. If somebody's nose is running and they're complaining of a lot of pressure in their face and around their eyes, more than likely it's sinus related. So it's not necessarily pain across the top of the head, it's more pain in here or in here, right around their eyes. It's usually always localized, and it's going to come on at the same time as other nasal or cold symptoms. Most of the time people will complain of these being worse in the morning, or if they're bending forward, just because you're bringing pressure into those sinus areas. And these will resolve when the sinus symptoms resolve. Fairly easy to tell apart. The last primary type are medication overuse headaches. And this is kind of an interesting phenomenon that if you take an agent, even an over-the-counter agent, too frequently, overly regularly, you can actually get a headache from taking the medication. And people who are at high risk for this are students. So I remember learning this in class, and my friend, who's now a pharmacist at Kroger, leaned over to me and was like, oh my gosh, this is me. So Kara Wyckoff suffered from medication overuse headaches. People will say it's just a continuous pain. It doesn't matter what I do, it always hurts. It's kind of a background pain, so it's more of like a nuisance, they'll say. They'll sometimes complain of it being most noticeable when they wake up. The only way to fix these, to get them to resolve, is to stop whatever you're using. And so typically people will have been using something prescription or non-prescription, and you'll see some common non-prescription agents on the bottom there, more than twice a week for over roughly 3 months. So if this is you and you feel like you have one of those background headaches, it's not overly annoying, but it's always there, stop your agent of choice, because that's more than likely what's causing it. All right. Any questions about those headaches? Are we all self-diagnosing here? All right.
How long after you stop using one of the medication or these headaches will you see?
How long until they resolve?
Yep.
It probably depends on the dose and how long it's been going on, but it probably takes about a week-ish to wash out your system. I'd say give it a week. Good question.
I'm not giving up caffeine, I was just asking.
Yeah, Mark.
Does extra sleep or like low and less sleep with headache, does it cause
Will that help?
No, like which headache, the cotension or migraine?
If it's improved by sleeping more, or if they just feel like they are more sleepy.
What does it cause? What cause?
We'll talk about it with triggers. So usually it's a lack of sleep that can cause a trigger for migraines. Not necessarily tension headaches, but typically migraines are very sensitive to anything that's dysrhythmic in your body. That's why hormones can sometimes trigger people, and usually lack of sleep can trigger people. Is anybody in here, if you were in high school and stayed up all night, did you still stay up all night, who am I kidding? Did you get migraines from that, anybody? Some people do. Okay, so who can't we treat? Well, more than likely, in every lecture class that we go through, when we talk about exclusions, a lot of it is just practical. So just think kind of practically. So most of the time, you don't want to treat anyone with a secondary headache. Remember, secondary headaches are a headache caused by something else, with the exception of sinus, because we can already treat sinus pain and pressure, so we can treat the headaches that go along with it. Other secondary headaches, you can get headaches from things like having a stroke. So why would we want to use over-the-counter products if they have a stroke? They need to be evaluated. Things like head trauma can cause headaches. They're all kind of big and scary and would need medical evaluation. So if they're coming in and you think they had a headache triggered by something else, more of the time it's going to be something major, and you're going to say, obviously refer somewhere else. Based on their symptoms. So patients complain of the worst headache I've ever felt. It's an exclusion. If it's severe, anytime symptoms are severe, we don't use over-the-counter products. It just makes sense. Somebody needs to evaluate that. If they have severe associated symptoms, so they're complaining of nausea, vomiting, fever, stiff neck, what are we thinking about? If you had a headache plus those things, what might that be? It might be something like an infection, so it might be the flu.
Concussion.
Might be a concussion. It might be meningitis. So stiff neck is a big one for meningitis. So anytime you're seeing like kind of the sum of the parts seems a little concerning, just refer them on. If the headache is lasting more than 10 days, whether you've treated it or not, obviously whatever you're using is not resolving, and usually headaches should not last that long anyway, so that would need to be referred on. And then a high fever, or if they have any signs of infection, so things like discolored discharge, mucus, if they're coughing up things, those would be more severe symptoms, probably indicative of an infection.
Where would you do the cutoff for like a moderate fever versus like a high fever?
We'll talk about fever later. Normally if it's over about 100-ish, if it gets up into the 101, 102, I say that's high. If it's below about 100, 101, it's probably just something we can treat at home, but we'll talk about that later. Usually it'll be with something else though, it just won't be a high fever. So high fever in this case is probably, let's say, 102, 103. And then if it's severe pain, it's probably over a rating of about a 6. And this is very gray. It's a gray area. Students don't like gray areas. OTC is a very gray course. So this is going to be a theme kind of moving forward. Other people we probably wouldn't want to use these products in are based on characteristics. So last trimester pregnancy, if they're having pain of any sort, they probably need to be evaluated, and a lot of products aren't recommended in that last trimester because you're going to get more exposure for the fetus. So more than likely you'd want to refer those patients on just to be safe. Less than 8 years old, that's basically for headaches. This is at your discretion. So if you have a child who's 5 and they come in and their parent says they're experiencing pain, most of these products can be dosed very low, down to about 6 months. So you can recommend it, but if you're having a headache at age 8, you might want to have them see a doctor, especially if they're frequent headaches, because that just seems odd, don't you think? And then history of liver disease has to do with one of the products that we use, and so that's why that's an exclusion. Other things based on the type of headache. So if patients are having chronic headaches, tension headaches that aren't going to go away, they're happening very frequently, it's probably something that needs to be evaluated. We can deal with episodic headaches, but not anything that's really OTC products should never be used for any chronic condition. Cluster headaches are usually rated on a pain scale as really severe pain, so you'll know they're a cluster headache from that. You'll talk about headaches actually in the P3 year. The other big thing people will commonly complain of with cluster headaches is it's the worst pain of my life. So again, it's not going to fit the other criteria, and that's why we exclude it. You would know if patients come in with a cluster headache. You can't treat migraine symptoms if they've not been diagnosed with a migraine. For the migraine sufferers in the room, a lot of people realize that OTC products don't always work well for migraines, and so you need to be evaluated so the physician is aware that you have migraines just in case they need to monitor your progress or what you're using and how frequently you're using it. And then the reason medication overuse headaches are excluded is because the treatment for those is no treatment at all. You basically remove whatever you're using. Does that make sense? Okay. So, what do we got as options? Well, we want to, our goals are listed at the top there, it makes sense. Our approach usually is always a dual approach with non-pharmacologic treatment and drug therapy. So it's a dual, two-sided approach. And we've got 3 different agents to pick from and over-the-counter products related to pain. And those are the salicylates, which most commonly aspirin, acetaminophen, and the NSAID class, and there's 2 options there. And typically we're looking at the relief of mild to moderate pain. If it's anything higher than that, we have to refer those people on. So, what kind of non-drug measures can you use? Well, it depends on the type of headache. So think about what triggers these headaches. So if it's a tension headache, things you could do to prevent them or to clear them up would be, if they're stress caused, you got to get people to relax. So whether that's breathing exercises, stretching. We said that a lot of people get tension that extends down to their neck and shoulders. So stretching, yoga, things like that will really help with tension headaches. I go to the massage therapist. It's awesome. And it clears my headaches up every time. Some people use like chiropractors too. I said it's all musculoskeletal, so if you're out of alignment, you're more likely to have these. Migraine headaches. So we got to think again about what triggers them. Sometimes heat and cold, depending on the person, can be a trigger. But in the case of migraines, cold can also be, for some people, a way to relieve pain. It's sort of a subjective thing. We talked about irregularities just kind of in your normal functioning. So make sure people are getting enough sleep. Make sure we try to do some hormone, if it's possible. A lot of people are on birth control to try to regulate hormone imbalances. Exercising, again, relaxation, and just avoiding anything that you know is a trigger for you. Most people have something that is more likely to trigger in them, not necessarily always. And then there are certain foods actually that can cause triggers, and you may not realize this. So a lot of these foods have a vasoactive substance in them, causes your vasculature to dilate, and that's thought to increase the likelihood of having a migraine come on. So some things contain nitrates, which are your cured meats, things like hot dogs, bacon, sometimes really green leafy vegetables or root vegetables like radishes. Tyramine is a vasodilator, and that's in things like red wine and cheeses. Phenylalanine, which is in artificial sweeteners like Equal. Caffeine can be both a trigger and something people use to relieve migraines, ironically. So some people it's good to avoid coffee or soda products that are caffeinated. Other people, you'll see like in Excedrin products, we actually use caffeine to try to treat migraines, which is kind of confusing. MSG, which is in a lot of Asian foods. And then theobromines, which are in chocolates, all are vasodilating substances. And so again, you want to avoid anything that's going to do that.
Are sulfate vasodilators?
Are sulfates vasodilators? No. Yep, Mark.
Which medicines can cause migraine?
Which medicines can cause migraine headaches? Is that on there? So sometimes it's related to, again, anything that's going to disrupt your sleep, anything that's going to disrupt your hormones, so mostly contraceptives or sometimes antidepressants can cause sleep disruption. So things that are going to hit your triggers are going to be the problems. That makes sense? Okay. So we're going to move on into the drugs. And it's important to understand how the drugs work in your body to be able to predict who can't use them and what the side effect profiles are. I don't know if you've had this with Dr. Pond yet, so if you have, stop me. If you have not, we'll go through this. So when you have trauma in your body, there is a reaction that's triggered cellularly, and typically it results in the production of arachidonic acid, which your body converts via an enzyme called COX, or cyclooxygenase, which is right here, to prostaglandins. Now you have prostaglandins in your body naturally, and they have sort of a dual function. They have a protective function and a disruptive function. So during homeostasis, COX-1, cyclooxygenase 1, is an enzyme that works to maintain kind of regular functioning in your body, homeostatic functioning in your body. So it's going to work in your GI tract, where it, in your stomach, maintains the level of acidity released, or level of acetic acid released by your parietal cells. In the kidney, it's going to help maintain normal GFR, or glomerular filtration rate. It's going to work on platelets, which is basically what causes clotting. So if you have an open wound, it's what causes it to stop bleeding, platelet aggregation. And then it works on your macrophage as well. So inhibition of COX-1 is not desirable because it maintains kind of the good things that your body naturally should be doing. There's a second half to that enzyme, though, that works in slightly different places called COX-2. It's an induced enzyme. So when your body feels pain, COX-2 is induced, and it causes inflammation, which basically is a trigger to your body that sensitizes it to pain. And so the thought is, by blocking the COX enzymes, you will have reduced pain sensitivity and will be able to decrease the inflammation that you might be experiencing. The problem is that most of the drugs we use over the counter inhibit both. Actually, all of them over the counter inhibit both. So they're going to block the harmful the process that we want to stop, that's going to reduce pain, reduce inflammation. They're also going to block the good things that your body naturally does with the prostaglandins that it makes. And so you're going to see issues with all the things in red there. So all of these agents, if they inhibit prostaglandins, which is what COX enzyme helps create from arachidonic acid, if normally COX-1 causes platelet aggregation, if you inhibit the enzyme, it's going to do the opposite. So what do you think is going to happen? You're more likely to have bleeding because you're not going to have platelet aggregation. Let's go with the GI tract. So if you inhibit normal protective functioning or acid secretion from your parietal cells, what do you think you might be at risk of if that normal process is inhibited? Ulcers. So you're not going to have the same normal balance in your stomach. You also have this endothelium changes, which is going to make you more at risk for the drug sort of penetrating that thin lining in your GI tract and causing ulceration. So it's going to cause the drug to kind of burn in to that endothelial lining. That's a problem. And then the kidney function is dependent on some of the agents. And then it's going to reduce inflammation, which is the good part. So we can kind of predict that all of these agents are going to have a very similar profile if they target prostaglandins. Does that make sense? Okay. This is kind of an overview of the different options we have and how they work. So let's just kind of go through. Onset of action is relatively similar. All of these agents work fairly quickly. The NSAID class, which is these two at the end, so your ibuprofen and your naproxen, are known as NSAIDs, and we'll get into what that means here in a second. They work the quickest, all the way up to 15 minutes. And onset of action is determined sometimes by whether you take these with food or not. So typically, if you take things on an empty stomach, they work the fastest. We'll talk about why with NSAIDs, so that's not always a good idea. How long do they last? Well, you can see here, so this is going to impact how often you have to dose them. Naproxen has the longest duration of action of on any over-the-counter product. Route of elimination is important because this is going to tell us which patients might not be able to use these products. So when you think about a medication that you take by mouth, it's got to get out of your body somehow. And there's two primary routes that most drugs are metabolized and eliminated through: renal or hepatic. Renal, obviously kidney, hepatic, liver. And so, of note, acetaminophen goes through hepatic elimination. That's important. We'll talk about why here in a minute. Mechanism of action is also important. So there's one here that's an outlier, more than others. We actually don't really know how acetaminophen works. Acetaminophen is Tylenol. We don't particularly know how it works. It's thought to inhibit prostaglandins, but it's going to follow a very different side effect profile than the rest of these drugs because it works differently. We don't know exactly how, we just know it's slightly different. So that's kind of an outlier. The key difference between the NSAID class, the two on the end, and the aspirin is this reversible versus irreversible inhibition of that enzyme that creates more prostaglandins. Irreversible inhibition is going to lead to more significant side effects. The reversible is going to cause the same side effects, but they're going to sometimes wear off more quickly, and so we'll talk through that. And then anti-inflammatory, this is kind of important too because more of what we're targeting, especially when it comes to musculoskeletal injuries, is the inflammation that causes pain. And some of these drugs do not treat inflammation, or only at high doses. And so if you have a patient who has something that's more throbbing, typically tension headaches are more linked to inflammation, the two agents that don't particularly have anti-inflammatory effects may not be your best selections. Okay, now we're going to talk through them individually. So you got your salicylates, which the main product is acetyl salicylic acid or aspirin. Anybody want to guess what acetyl salicylic acid, what a core component of that is? What's a building block of acetyl salicylic acid? It is acetic acid, aka vinegar. So if you ever have outdated aspirin, it will smell like a bottle of vinegar. Tell me if I'm wrong. Let's see if I got some other ones. True? Childproof. Yeah, you got it. Yep, that's Let's see if I got another one.
Come on, Sam. Do us
Down
wrong.
in there. Down in there. Yep, still stinky. All right. Yeah, they're stinky. So one great way to tell people if they're worried about whether their product is good or not and they have aspirin at home, tell them to smell it. If it smells like vinegar, throw it out. It's not necessarily bad, it's just going to cause a lot of upset stomach. There are a couple... Alright, hang in there. I warned you. There's another type of salicylate. We're not going to talk about magnesium salicylate too much just because it's not very common, but that's in things like Dones and Percogesic. So these are the brand names here. And you'll commonly hear baby aspirin, the term baby aspirin, and that's going to refer to 81 milligram aspirin, just in case anybody's unclear on that. Anything that's in the boxes I want you to know. So I don't ask you to know doses very often, but I want you to know analgesic doses. Let me say that again. I want you to know analgesic doses. The whole semester. They'll come back. They're fair game at any time. So memorize these for adults and kids. Because it's very important that you know mostly the caps and how often they're dosed, because you're going to get these questions quite a bit. So you can see there kind of the dosing range. How is aspirin eliminated? If we go back about 2 slides, somebody flip back. It's renal. So if you have somebody who has poor kidney function, has any sort of kidney disease, they're going to have a significantly lower dose. Or they may not be able to take this at all. Because it's going to hang around in their body longer if their kidneys aren't functioning to chew it up. Things you have to know about aspirin: you can overdose on it. And the most common way is acute salicylism. Which is basically where you're taking high levels over a long period of time. And the common side effect that people complain of, and it's sort of a, I guess a unique one to salicylates, is tinnitus. Anybody know what tinnitus is? It's ringing in your ears. So if you have someone who's complaining of, I just can't get this ringing out of my ear, it's very annoying, ask them if they take salicylates. More than likely they do. You can also have acute overdoses on these. You take very large quantities in a very short amount of time. And that's, especially in kids, very, very dangerous. Just think about the big side effects, right? Bleeding. That's a big problem. We don't want to have anybody to have internal or external bleeding. So this is a poison control and emergency department referral if you have a child that gets into aspirin. It's very serious. Common side effects with aspirin are related to the side effect profile. So because it's making your GI tract more susceptible to injury, you're going to see things like epigastric discomfort, basically just upset stomach, dyspepsia. Anybody know what dyspepsia is? Somebody Google that. And nausea, vomiting. Usually just upset stomach mostly, because it's going to be irritating to your GI tract. And people who are on higher doses are more prone to having stomach ulcers. There are some drug interactions here, again, mostly related to bleed risk. So because this is going to inhibit platelet aggregation, anything else that's going to put you at higher risk for bleeding has an additive effect, and that's a problem. So NSAIDs, we'll talk about it in a minute, also can increase your risk for bleeding, as can anticoagulants, which actually work specifically to keep your blood a little thinner. So big anticoagulant, and this will come up in this course multiple times, is warfarin. So let's just get that definition out now. Warfarin, which is a generic, is an anticoagulant. It keeps your platelets from sticking together, and it's used in people who need to have less congealed blood. Typically people who have heart issues, that blood's not flowing as easily. So they need to keep it very thin so that it can move easier, I guess is the simplest way to say that. So anticoagulants, again, collectively are going to increase your bleed risk and put you at higher risk for those things to happen, which we definitely don't want to get into. Not going to talk about the antihypertensives, just know that they can interact with drugs that treat high blood pressure. And then alcohol, because alcohol can actually put you at risk for GI bleeds, and so that additive problem again. And they should all smell the same, so if you've gotten a whiff of aspirin, you got a whiff. Okay, other things to be aware of with aspirin. If you haven't guessed already, I don't use aspirin for pain very often. I hardly ever recommend it for pain. And I would suggest you probably didn't either, because there's a lot of risks associated with high doses of aspirin. Most people don't have an issue with not tolerating aspirin therapy. However, you never know when you might come across someone who does have an intolerance. And if people have an allergy to aspirin, they usually display one of 2 symptoms. They can have angioedema or swelling, or they can have a bronchospasm type where they may have difficulty breathing. So, if you have the bronchospasm type, that kind of links into why we may not want to use it in patients with asthma. So patients with asthma have difficulty breathing already. And what if we give them aspirin and it sort of, it's not tolerated in them? We're going to trigger an asthma attack and they may not be able to breathe because their lungs are not going to be working properly because of the bronchospasm. This is one of two reasons we don't use aspirin in kids. So if you look back on the dosing, normally it's only for kids above age 15. One of the reasons is asthma is most prevalent in children, and it's very highly undiagnosed in kids. So we don't want to have an undiagnosed asthmatic take aspirin and have a reaction and then not be able to breathe. Does anybody know the difference? I think we talked about this before, but between warnings, precautions, and contraindications. We talked about this last semester early on when we looked at package inserts, but I think it's a point worth clarifying. So what's the most critical do not use in this group? There were three options: warnings, precautions, contraindications. So warnings are number one. Then I would probably actually say precautions. Contraindications are flexible. Most of the time you should avoid, and these I guess are kind of together, you should avoid it if possible, but under supervision you may be able to use a drug that's contraindicated in a patient. But typically warnings are your most critical, the first thing you look at. They're the big problematic things. Contraindications are things that don't go well together. Warnings are problems that could happen in anybody, and they're more likely. Or if they happen, they're big problems. So they are kind of, I guess, elephants of a different color. That may not be a fair question to ask. As far as the other people on the contraindications, obviously if you have an allergy to a product, you shouldn't use it. Nasal polyps relate to, again, breathing issues similar to asthma. So if they have an intolerance, they're not going to be able to breathe as well. I'm not as focused on you knowing that you can't use aspirin and nasal polyps. But I do want you to understand that if they have any sort of bleeding disorder, aspirin's off the table. Are we pretty clear on that? Bleeding, risk, no aspirin.
So is aspirin more blood thinning than other NSAID?
Yes. And so Mark's question was, is aspirin more blood thinning than NSAIDs? And the reason is that overview table. It has to do with the irreversible inhibition of COX-1 and COX-2 versus the reversible inhibition. So the bleeding risk is going to be higher because you're not, that prostaglandin is not going to follow that homeostatic process until your body makes new prostaglandins that don't have that, that enzyme inhibited. It's going to take some regeneration. So yeah, bleed risk is much higher in aspirin. They actually use aspirin clinically as a anticoagulant. It's not as potent as some of the options we have on the prescription side, but they'll specifically use it to thin blood too. Okay, so anything that's bleeding disorder, anything that's dysregulation in your GI tract too, so peptic ulcer disease, or sets you up for more risk in ulcers. Okay, I said there was one reason why we don't use aspirin in kids, and that was this aspirin bronchospasm reason. The other reason we don't use aspirin in kids is down here. So, in children, there is a risk of something called Ray's syndrome. Anybody ever heard of Ray's syndrome? Anybody know what Ray's syndrome is? Okay, so Ray's syndrome is a progressive neurological damage that occurs kind of unpredictably, usually in kids, and it starts with a viral infection. And use of salicylates in children who are prone to developing Ray's syndrome can actually be deadly. It doesn't happen all that often, but it's related to children who have a viral infection and a fever. If they take aspirin, they are at risk for developing this neurological damage. So that's the second reason we don't use aspirin in kids. Because we don't necessarily, it may not happen overly commonly, but if it does, it can be kind of catastrophic. And so can bronchospasms in a patient with asthma. So it's just not worth the risk. They're easier, better agents. The reason we don't use aspirin in pregnant women has to do with prostaglandins have a normal role in bringing on uterine contractions. And so if you are inhibiting the process that creates that, you could have prolonged labor and delivery, which could ultimately cause problems for the baby during delivery. That's why we don't use it.
Are there tests that are done for children that could get Ray's syndrome?
So Kristen's questions are, do they test for people who are at risk for Ray's syndrome? No, they don't. They do not. Okay. As far as warnings and precautions, again, I think it makes sense, bleed risk, and we talked about renal insufficiency already. And I think we talked through this. So pediatrics, we talked through the two primary reasons why you don't use aspirin in kids. Talked about pregnancy. Also, really, why would you want to have a high risk for bleeding in a pregnant woman? That's not a good risk to try. It's excreted in breast milk, so again, we wouldn't want a child to have any risk for bleeding. And then older adults are already at high risk for bleeding. They're also at high risk for falling, and a bleed in someone who falls can be a problem. So there's really you and I can use aspirin for headaches, but there's still better options out there. So that's my take. They've been playing around with a lot of other uses for aspirin. So the most likely cause that people are going to come in for aspirin in your day-to-day as a pharmacist will either be to thin their blood. They'll use it for blood thinning purposes. Or sometimes they use it for just general heart health. So there was an idea that taking a baby aspirin every day was a way to prevent heart attack, stroke, reduce your risk. And that's been changed over the years. You'll talk about that in cardiology. They do not recommend it as strongly as they used to. So more to come on that. And then there was actually a study done about risk of reduction of cancer mortality with aspirin therapy, usually low dose, ongoing aspirin therapy. And it has sort of a mixed review. I think it was in colorectal cancer. Dr. Oz had it on his show, and people got a gazillion questions about it. But the data is just not great. And the guidelines currently do not recommend aspirin for any sort of cancer prevention. Do you have a question?
Yeah, on the baby aspirin thing, I had heard that they more or less had said you should only even do that if you've had a history of having like prior issues, not like don't do it as like a preventative measure, I guess.
So a lot of people would come in and buy baby aspirin just to take it. So you turn 45 and somebody would wander into a pharmacy like I feel like I should take this. It's really only at the recommendation of your physician, usually because of family risk or personal risk. All right. So now we're going to get into acetaminophen. Again, know the box doses. One very important thing about acetaminophen is the max dose. It's also a gray area. Sorry. So acetaminophen, which is in your Tylenol family of products, if you look at clinical literature, so if you look up in Micromedics, if you look up on Lexicomp, one of the drug databases, it'll say you can't give more than 4 grams a day. However, because of the risks associated with overdose, the manufacturer actually elected to label their products with a max of 3 grams a day, depending on which product you buy. It's 3 to 32.50. So 3,250. Where am I going to tell you to cap it? It's flexible. So depending on you and I, we can probably take 4 grams a day. We'll talk about who probably shouldn't use this. So think back to that overview slide. How do you metabolize acetaminophen? Liver. It's liver. So anybody who has any sort of liver liver, like cirrhosis, if they have any sort of hepatic dysfunction, you probably actually want to cap them at 2 grams a day. Older people, they sometimes will recommend 2 grams a day. So depending on how likely it is that you're going to have exposure or higher exposure, you cap it a little lower. So if you want to be safe, you could generally tell people to follow the package instructions and use 3 grams a day. But there's some controversy, you can go up to 4. You should definitely never exceed 4. Yes?
Don't they also recommend that you never take Tylenol like after a day of drinking?
Yeah, and we'll talk about that. So you don't use Tylenol with alcohol.
You said it was the manufacturer that reduced these things. So who made everybody reduce the 500 milligram strength tablets like in?
So that's a great question. So Greg's question was, if you work in a pharmacy, you know that like Vicodin went and had to lower the amount of acetaminophen component from 500 to 325. That was an FDA call, and it was because of how they dose it. So because of how physicians were dosing the frequency of Vicodin, people could exceed even 4 grams a day. And so they did that to limit, because most people take products like Vicodin, and the majority of the pain relief they're getting is probably from the opioid component, not from acetaminophen. And so they did it basically for safety reasons. This will be highly contentious. They probably will change this in the future. So as long as you know 3 or 4 grams a day is the max. It might just depend on which reference you're looking at. Okay. You can just cross this slide out. This is old. There was some issues with children's versus infant dosing, and they have since streamlined that. It's been long enough that probably isn't an issue. One of the great things about Tylenol or acetaminophen is that there's very few side effects. They're actually very rare. There are very rarely do people experience side effects with this product. On the flip side, some people say taking Tylenol is like taking a glass of water. Anybody ever experienced that? I take Tylenol and man, it does absolutely nothing for me. You'll hear a lot of patients say, well, I don't even bother with Tylenol, it doesn't help. Remember back to, again, the overview slide. So how does Tylenol work? We don't know. We think it works on prostaglandins, but we're not entirely sure, and we know it doesn't have any anti-inflammatory properties. So, if people have pain that's inflammatory based, so you're seeing redness, you're seeing swelling, they're complaining of throbbing, Tylenol may not be the best option for them because it does not treat inflammation. We don't know how it works, but we know it is not very good at treating inflammation. So keep that kind of in mind. Again, because it's hepatically metabolized, you're going to see interactions, side effects, warnings related to liver. So we've got alcohol, which there's a possibility this can cause bleeding. It's very, very low. I don't even have it listed here. But alcohol is going to kind of stress your liver. Your liver metabolizes alcohol. So your exposure risk is higher. So you could go over that 4 grams a day. And this is hepatotoxic, which means it will cause damage to your liver at high doses. And then for patients who are on anticoagulants, even though we don't know exactly how this product works, it is the drug of choice for them. So if somebody comes in and they're on warfarin, on something that's thinning their blood, more than likely acetaminophen is probably what they're looking for. You can overdose on it, I just mentioned, and liver failure or injury is the risk you run. So that's, again, why we really want to keep people at as the lowest amount possible per day. The symptoms are kind of nondescript, honestly. And then you can see there about liver, again, not using it in patients with any sort of liver issues. And to Kristen's point, if people are consuming over 3 alcoholic beverages a day, they would not want to use acetaminophen. Okay. On the plus side, this is probably the drug of choice in nearly every special population. So it's safe in pregnant women, it's safe in breastfeeding mothers, it's safe in kids, and usually it's the drug of choice in older people. Okay, that brings us to our last class, which are the NSAIDs. I told you I'd define it. So NSAIDs stand for non-steroidal anti-inflammatory drugs. So it says right in the name that these treat inflammation. The two over-the-counter products that we'll focus on are ibuprofen and naproxen. So ibuprofen is your Advil family of products, naproxen is your Aleve family. And you can see all the extensions there. Again, know the box doses and the max. Everything in the boxes is fair game. Naproxen does have an age restriction just like aspirin, and this is mostly due to the duration of action. So remember, naproxen is your long-acting agent. You dose it every roughly 12 hours is how long it's lasting. And so usually you don't want to use long-acting agents in kids, just because if there was an overdose situation, it would take longer to clear that from the body. Okay, things with NSAIDs, side effects. The big ones are GI upset. So if you remember back, mechanistically, these are the reversible inhibitors. So they're going to cause a lot of the same side effects as aspirin. We're going to consider bleeding, we're going to consider ulcers, and then they have some specialty things too. So should look very similar to aspirin side effects of GI upset. And then the kicker, the unique thing about NSAIDs is this cardiovascular component. And so there is some risk because of other places where prostaglandins work are found in your body, that you may see some swelling or palpitations, which are where you can kind of feel your heart race, palpable heartbeat. If you think about, again, these are COX-1 and COX-2 inhibitors. If you've been reading the news in the past 10 years, anybody remember Vioxx? When you talk to Dr. Panis loved Vioxx. He will talk about it all the time. Vioxx was pulled off the market because of cardiovascular risks. And that's why when we get into the black box warning in the next slide, most of that came from Vioxx. And so that's why we still see some cardiovascular adverse effects that are probably noted on boxes of any sort of NSAID that you buy over the counter. To avoid the GI upset, any idea what you tell people? This is an important counseling point with NSAIDs. It's always with food or milk. Something on your stomach will prevent that GI upset. And the most important class, routinely, to always counsel that, to make that point with, are NSAIDs. Always tell people to take this with food. Every time. Because they will get upset stomach. Okay, so here's the black box warning, and like I said, Vioxx was a product that was a COX-2 selective, so it was kind of a half of how your ibuprofen and naproxen work. And they found, in a study done by the drug manufacturer, they found that that a COX-2 inhibitor doubled the risk of cardiovascular problems. And so they've extrapolated that to the OTC products. And so that's why you see usually these big warnings about risk of stroke, risk of heart attack, which is myocardial infarction on there, and then risk of serious GI bleeds. Because you have those risks, again, you're going to avoid these products in people with any sort of heart condition or heart risk, any sort of ulcer risk or bleeding risk, and then lastly, any sort of kidney dysfunction, because you're looking at it's renally cleared. So I think that pretty much covers all the precautions if I'm looking through. GI problems, bleeding. As far as drug interactions, these mostly have to do with bleeding risk as well. So again, we talked about aspirin, and if you use aspirin plus an NSAID together, you're getting that that building, that cumulative bleed risk, and same with anticoagulants and alcohol. So it's all about kind of mounting risk. As far as special populations, remember the age restriction for naproxen. Typically older adults, just like with aspirin, are higher risk for bleeding, and so we tend to try to avoid these products in older people. usually, again, avoiding these in the 3rd trimester pregnancy for some of the same reasons as you'd see with aspirin. So there's a lot of commonality between NSAIDs and aspirin, with the exception of that cardiovascular risk. And in general, these are a little better tolerated, I would say. So most people, an NSAID is their drug of choice when it comes to pain. And they would be safe in UNI. So here's kind of just a table comparing the different options, and I'll let you guys look that over, but that's kind of a summary. You also get combination products over the counter. Yeah, Danielle?
I just had a question. Acetaminophen is also antipyretic, isn't it?
All of these are antipyretic. So antipyretic is fever reducers, and we'll talk about fever in a later lecture. But yeah, all of these will treat fever. They'll reduce fever. Good question. They all come in various combination products too. So I mentioned earlier that you sometimes see them with caffeine, and typically those are migraine-specific products. Excedrin is the big brand name, and that is shown efficacy, although mechanistically it's kind of confusing because if caffeine is a trigger for a migraine, why would you use caffeine as a treatment? And I'll be honest, I'm not exactly sure why that is, but for some people they swear by that. An analgesic plus a decongestant you're going to use in a sinus headache. So you're going to target both the pain and the underlying condition, which is just the sinus pressure. And we'll talk about decongestants in a couple of weeks. And then sometimes you can also use an analgesic plus an antihistamine. And we'll talk about antihistamines and allergies. They're very sedating. They make you sleepy. And so things like Tylenol PM are going to have an antihistamine in them, as well as your cough and cold products sometimes too. As far as natural and complementary therapies for pain, and then we'll take a break and do some quick cases. There's a lot of more Eastern medicine that focuses on pain, and mostly it's that musculoskeletal underlying reason, but there's some herbal products as well, and dietary supplements. So the reason these supplements are thought to trigger, to treat headaches is basically related to triggers. And so it's thought that people who have low levels of all 4 of these different dietary supplements might, in their diet, might be more prone to having migraine onset. And so sometimes physicians will recommend actually supplementing any or all of these as a way to reduce the frequency of migraines. You can also use peppermint. Peppermint will stimulate cold sensitive receptors, and so sometimes people put it on their temples or smell it. If you're applying it topically, sometimes you can have skin sensitivity to it. Otherwise, nothing really to be concerned of. And it's topical. You wouldn't actually want to use peppermint orally. It would not help with pain for that reason. There's another one that's somewhat helpful, and again, it's got a grade B. Remember, grade A has the best evidence, and then as you go down, it's lower evidence or lower efficacy. So willow is kind of in the middle in terms of efficacy. It has an active component, though, known as salicin. So if you're guessing about what side effect profile it's going to follow or how it's going to work like a salicylate. It's going to work like aspirin. So again, we're worried about bleeds, and we're not going to use it in all the other populations that can't use salicylates. Feverfew is another one, and it's specifically for migraines. Anybody ever used Feverfew for migraines? Okay. The adverse effects are primarily GI related. You can see them there. It's actually from a natural product that's in the chrysanthemum family. So if people have any sort of allergies to marigolds, chrysanthemums, daisies, it's all the same genus, I guess, of plants that this comes from. And there's possible cross-reaction for people who have ragweed allergies, which is a lot of people. So you might just ask if they have any sort of seasonal allergies before recommending this. There's also this Head-On product, which honestly has no efficacy data whatsoever, but it's out there. And you actually apply this to your forehead at the first sign of a migraine. I wouldn't recommend it. I think it would just cause your head to get red and probably irritated. So it's probably not going to do a whole lot. Okay, so big counseling points, things you gotta remember about analgesics. Most of these are gonna cause stomach upset. So your NSAIDs for sure, your aspirin, yes, and then acetaminophen doesn't really cause any side effects, so not necessarily imperative for it. But for your NSAIDs and your salicylates, make sure to take it with food, absolutely, every time, always. Always with food. With all of these, because of the risk for rebound headaches or medication overuse headaches, you want to try to take people, recommend the shortest dose or the lowest dose for the shortest duration. And we know that toxic amounts, especially with acetaminophen, can be very problematic, so it can lead to liver damage. So think low doses. Remember that if you're treating a patient or not, if they've had a headache for 10 days, you need to refer them on, because you really shouldn't have a headache for that long. Be careful, because some products have these hidden in them. So like I mentioned, cough and cold products oftentimes have acetaminophen in them, and patients might be on something prescription, like Greg mentioned about Vicodin. So you have to add up all of the sources of acetaminophen, for example, that they're getting throughout their regimen to get to that max total daily dose. Because we don't want people to accidentally have it be overlooked because they're taking it in multiple forms. And that's very common. I'd say the most common one that people forget to claim is the Tylenol or Advil PM, the at-night products. They don't remember that those have the same active ingredients in them. And then just other considerations, I think, that we've belabored enough. Remember, you don't use aspirin in kids. There's 2 reasons. First reason has to do with aspirin intolerances. So what happens if you have a patient who's a child who has an aspirin intolerance? They could run a risk of bronchospasms, and if they're an asthmatic, it's going to trigger an asthma reaction. They're not going to be able to breathe, and that's a big problem. What's the second reason? Reye syndrome. So if you give aspirin to a child with a fever, they could develop Reye syndrome, which leads to long-term neurologic damage. Not good. Okay. Any questions before we take a little bit of a break and then do some cases? Deborah.
When you say, you might have already gone over this and I just missed it. When you said if the headache's lasted 10 days, how on and off can that be? Or does that mean 10 straight solid days?
So it's a gray area. That's a good question. I would say if it's pretty consistent throughout 10 days, that's still abnormal. So it doesn't have to be all day, every day, but if it's gone on for 10 days, I think that's a problem. Any other questions? So remember exclusions, if it's too painful, if it's severe symptoms that accommodate it, if it's gone on too long, it's really based on kind of a feel. So if you want to take a little bit of a break, we're going to come back and do some cases just to figure out what questions would you need to ask and what kind of products might you think about.